Everyone. Thanks for joining the Enhancing Access to Pediatric Behavioral Health Amidst Shortages webinar session part 2. My name is Matthew Salaga from the HRSA Office of Intergovernmental and External Affairs, Region 1 in Boston. We will begin with a couple of housekeeping items. I will then tell you a little bit about IEA. After that, I will turn it over to our main presenters. Next slide, please. This webinar session will be recorded, and the link to the recording, presenters' bios, and the slides will be shared with everyone. We encourage you to submit your questions at any time during the session on the Q&A pod. Our team and presenters will be monitoring and answering as questions come in. Lastly, your feedback is very important to us. We will share a quick evaluation poll for you to help us serve you better in the future. We would appreciate it if you could please take a minute to complete the poll at the end of the webinar. Next slide, please. I would like to kick things off by underscoring that the Health Resources Services Administration is strongly committed to the behavioral health and well-being of our nation's children. Today, IEA is pleased to partner with our sister agency, the Maternal and Child Health Bureau, to help leverage our federal programs and resources to address the critical mental health needs of children and to expand access to high-quality pediatric care, including mental health services. Today, we will have the honor of listening and learning from Dr. Sarah Hagan from the Division of Child and Adolescent Psychiatry at Rhode Island and Hasbro Children's Hospitals. Also with us is Catherine Wolf from the Maternal Depression Grant Program Administrator from the Vermont Department of Mental Health. And finally, Dr. Sarah Guth, a consulting psychiatrist for the Perinatal Mood and Anxiety Consultation Service at the University of Vermont Medical Center. Following Dr. Guth's presentation, Reed Plimpton from the Northeast Telehealth Resource Center will inform us of HRSA Telehealth Resources. And finally, we will conclude with Madhavi Reddy from the Maternal Health and Child Bureau, who will provide some closing remarks. Next slide, please. Our agenda includes different perspectives, model practices, and opportunities which will assist you in gaining awareness of programs and investments related to behavioral health available from HRSA, discussing effective strategies to enhance access to affordable, community-based treatment and recovery support services, identifying opportunities to offer care coordination support to pediatric healthcare providers and healthcare providers serving pregnant and postpartum women, and gaining further insight into the continuum of behavioral health services and collaborations between primary care and hospital-based services. Next slide, please. So just to touch on HRSA's overview of HRSA, we at HRSA support more than 90 programs through grants and cooperative agreements to more than 3,000 awardees, including community and faith-based organizations, colleges and universities, hospitals, state, local, and tribal governments, and private entities. Every year, HRSA programs serve tens of millions of people, including people living with HIV/AIDS, pregnant people, mothers and their families, and those otherwise unable to access quality health care. Next slide, please. Our mission at IEA is to provide on-the-ground outreach to increase the reach, impact, and awareness of HRSA programs. Next slide, please. And our core functions. The role of IEA is different than other components of HRSA. IEA does not award or manage grants or cooperative agreements. Instead, we work across HRSA program areas to extend the reach of the Bureau's offices and to provide an additional touch point for HRSA stakeholders. Our work can be categorized by these core functions: external affairs and outreach. IEA staff oftentimes serve as the face of HRSA by providing local representation at meetings and events to promote HHS and HRSA initiatives and programs. Strategic stakeholder partnerships. IEA develops and maintains key partnerships in communities, states, and regions on behalf of HRSA. Regional surveillance. IEA is uniquely positioned in the field, and therefore we are able to gather and assess ground-level intelligence about healthcare issues and trends in order to provide HRSA headquarters with the information that may impact decision-making about our programs. And regional management. The administrative side of our work. IEA ensures the efficacy of HRSA regional resources, which include management of human capital, technology, and facilities. Next slide, please. I encourage you to contact any of our 10 HRSA IEA offices around the nation. if you'd like to get more information, have questions, or would like to partner with us. And now I would like to hand it off to Dr. Sarah Hagan for her presentation. Sarah, you may take it away. Next slide.
Gotta unmute myself there. Okay, so thank you so much for having me back to share more about PDPRN and PMHCA programs in general. I'm also very excited to be presenting with Sarah and Catherine from Vermont and learning with you all about their maternal mental health program as well. So I'm looking forward to that. Next slide, please. I'm going to get this out of my screen. There's something there. Okay, so for those of you, just a quick refresher. So for those of you who may not remember or did not attend the first session of the series, I did present a little bit about our program. So Rhode Island's Pediatric Psychiatry Resource Network, otherwise known as PDPRN, is one of now many pediatric mental health care access programs across the country, which I'm excited about. And we're all supported by the Health and Resources and Services Administration. We're designed to support pediatric primary care providers meet the mental health care needs of their patients. And, our program in Rhode Island is designed specifically after Massachusetts MCBAP. So shout out to John Strauss for starting these types of programs and teaching us all about how to make them happen in our own states. And then I'm always proud to say that we're located at Bradley Hospital, which is our nation's first psychiatric hospital exclusively for children. And we wouldn't have these programs without the support of our funders. So just a quick thanks to them as well. Next slide, please. So, as everybody's probably well aware, due to the declarations of emergency and extensive media coverage, that the rates of youth seeking mental health treatment is increasing. And in Rhode Island, we're also seeing that. We're very fortunate to have a mental health triage service and referral network called KidsLink, which can be accessed by anyone, a parent, a teacher, a pediatrician, child themselves, to address youth mental health concerns. And we can have also seen a market increase in the number of calls seeking mental health services for Rhode Island youth. And you can see the numbers there in 2019 to 2021, they've basically doubled. And then in addition to this increased demand for mental health services, we have a mental health work shortage, which preceded the COVID pandemic, resulting in pediatric primary care providers having to address the mental health needs of their patients more directly than they ever have before. And I actually asked one of our pediatrician champions what those numbers look like. And she provided that on a day in May in 2016, approximately 1 of her 30 patients were scheduled for a mental health-based visit. And on that same day, in 2022, 11 of her 31 patients were scheduled for a mental health-based visit. And if that just gives you some concrete view of what has been happening in the pediatric offices. And she also made a point of noting that these were planned mental health visits, but as mental health assessments have become more standardized in pediatric practice workflows, it is common for patients coming with somatic complaints or even just wellness visits to also become mental health visits, mental health focused visits. So it's important to note that those numbers probably may be even higher. And the PCPs are managing this the best they can. Thanks to telehealth, they're able to do more mental health monitoring and treatment. And they're also taking on more complex mental health cases while their patients are on long wait lists to be seen by mental health care provider. Next slide, please. All right, so we've established some background. So how do programs like PDPRN help? So this is the list of services we provide to the PCPs or the pediatricians to address the mental health needs of their patients. The consultations really are the key component, but lately, in the past few years, it's not uncommon for pediatricians to share that they no longer have time or space in the structure of their day to call, and that they're also taking on more patients and have more complex needs in terms of the mental health guidance that they're looking for. And so we've worked hard to continue to develop additional tools and resources for them. Next slide. Next slide. Thanks. So I've shown these before, so I'll just run through them really quickly, but we've obviously been developing more tools that can be used for telemedicine behavioral health visits by pediatricians. Next slide. Next slide. Including scripts that they can actually read or, kind of adapt their own language to work with children when they are expressing anxiety or depression or other mild to moderate mental health issues. Next slide. And next slide. Okay. And so I just want to point out too that, we've continued to evolve these things. So we've recently added this ADHD action plan. It was created at the request of a practice looking for additional tools to address, the ADHD that they're seeing in their patients. And I think I mentioned this in the last presentation, and many people reached out and asked for a copy. So I did provide that as an additional resource to be distributed to everyone today. So you can take a closer look at that. Next slide, please. Okay, so we continue to evolve and develop. It's not just the tools and resources that we have, but we've also revised our website to include online scheduling of consultations. This came about because, unfortunately, pediatricians were saying that they're finishing notes late into the evening, and so they want to call to schedule a consult, but that's not when we're open. And so it's hard when it's on the forefront of their mind when they're kind of thinking about the patient as they're finishing their documentation, to not just be able to quickly access the schedule to book a consult. So we've adapted our tools to help them in that way. And then we also created these monthly office hours, and in the bottom of the screen you can see some of the feedback that we've gotten from pediatricians about having these tools. So again, this came out of the need to provide consultation outside of just consultation call times due to limitations to that workflow. And so we set up these office hours to once a month via Zoom, where our PDPRN staff and the staff of a practice can get together and discuss cases and talk about different mental health needs of their patients. And it's nice because a lot of the providers will actually save up their cases throughout the week to talk to us, but they still call, when they need to get answers for consultations, when they need to get answers more quickly as well. Next slide, please. Oh, these are circles. Next slide. Next slide. The other thing we do is we also try to partner with other programs working to improve access to mental health care. So, one of our biggest goals is to improve access to mental health care for all children in Rhode Island. And there's other programs that are doing that too. So we're trying to provide linkages between our program and other programs throughout our state that are working to improve access. And this is a program that I referenced before, Kids Link. This is our wonderful mental health triage and referral service in Rhode Island. And, by working together, we can help facilitate the referral process for pediatricians. So an example might be that, if we take a consult from a pediatrician, and based on the information and the discussion about that case, we're saying, I think that patient might benefit from a higher level of care, like a partial program or something. Instead of having the family have to call or the pediatrician have to call Kids Link to, start this process all over again of getting a consult and having the patient triage the service, we can kind of coordinate behind the scenes to help make that connection happen and save time and resources in terms of moving things forward for that specific patient. Next slide, please. The other coordination we do that's wonderful is a partnership with our maternal depression and related behavioral disorders program, Rhode Island Moms PRN, and you're going to hear more about these MDRBD programs from my colleagues in Vermont in a few minutes. But we work together to provide outreach and coordinate when cases arise that there's overlap for. Again, similar to Kids Link, where, to try to help pediatricians have access to the support that they need readily without having to add a lot of work to them as much as possible. And there's other programs throughout the state that we are partnering with as well, including programs like CTC Rhode Island and PCMH Kids. All of those programs are working on increasing access for mental health services for youth in Rhode Island. And our partnerships really help kind of make those services shine and make our service shine as well and make us all efficient. Okay, next slide, please. So those are some things that we're doing to support the process. I'm going to highlight here how these programs work because I think it is really important. We're a pediatric mental health care access program, and a lot of folks will kind of say, well, how are you specifically increasing access? And I think that's a fair question. So I like to kind of provide a visual demonstration first to give you a sense of how this works. So the programs are designed to help pediatricians address the mild to moderate mental health conditions in their patients. And right now the pediatricians might be taking a little bit more of that, but for the most part, we're still able to increase access to mental health care. And by But we do that by, next slide, please, kind of allowing every child and adolescent that's treated by a pediatric primary care provider in our state to benefit from our services. So what happens is a pediatrician will call and consult on a patient. But the thing that we have to keep in mind is that pediatricians are intelligent and passionate about caring for their patients, and they're very efficient. And so when they consult about PDPRN, they're not just consulting about this one patient. Next slide. They're actually absorbing the information and the knowledge that they've gained and in that consult and taking it to every visit with every patient they treat. And they're applying it as needed. And if you think about that in numbers, it's estimated that pediatricians carry a caseload of about 1,000 youth at one time. And that means that one call from PDPRN really impacts the mental health care access for 1,000 Rhode Island youth at a time. So you can see how supporting pediatricians to do this work can be really helpful. I'm going to add another component to this that I think is really important to note. So next slide. Pediatricians also talk to each other and work together. You can pull that up. Great, that's fine. The next slide too. And work together. They typically work in practices and trust each other and go to each other for advice about cases as well. And so I think it's really important to think about that too. So that one call that, Dr. Joe called about that one patient, if Dr. Joe is talking to Dr. Cindy and about a similar case and is going to carry over that same advice and knowledge, we're talking about now impacting all of the children that are potentially receiving care in that practice. So I think that's an important thing to think about too, in terms of how much access or outreach we can actually have in our programs. Next slide. Okay, so this is all great in theory, right? This is my theory about how this works. And I think it's really important to note that we actually have a little bit of data on this as well, that the PMHCA programs increase access, and we were able to kind of take a deep dive into the data that we have from the All Pairs claims database in Rhode Island. And the important point is the second bullet really that I'm talking about here. And what we looked at was the practice patterns of the providers that use our program from before our program existed or they accessed our program to after, compared to providers that aren't using our program as well. And what we're seeing is that they're having higher rates of patients receive mental health treatment, those providers that use our program. So that those pictures that I had up there, we're starting to be able to demonstrate that we have some data to back up that theory, which is great. So we're seeing that there's an increase in that the mental health treatment that's being provided by those providers, and therefore our access is working, which is great to see. The other point I think to point out from this slide, just quickly, is that we have an education and training program as well called the Pediatric, our PDPRN intensive program. I'll just say it that way instead of getting into all the details. But we've been looking at the outcomes of that. And I just want to highlight here too, that we're also through our educational series able to increase pediatricians' comfort with addressing the safety concerns in their patients, which I think is really important, especially given the crisis that we're facing right now. So, through our services, we're able to hopefully improve the safety of patients as well. Next slide, please. Okay, so I just want to highlight that very excitingly that there are a lot of us that exist. We're not just in Rhode Island. And so these are some of the links to the regional, the Northeast Regional PMHCA programs. So you can find those here. And then if you're calling in from a different part of the country, you can access the NCPAP, the National Network of Child Psychiatry Access Programs, or the HRSA PMHCA websites to see about the programs in your state as well. Next slide. And this picture is really nice. This is from the NCPAP website, but you can see how these programs have expanded. And at this point, the color is pretty much across the entire country, which is very exciting. And so our programs are starting to become more of a part of the standard of care for youth mental health treatment, which I think is great. And I hope that those of you who are learning about this program for the first time, or maybe have had, have had no experience with it, to reach out to the programs in your state to connect with them and access these services and see how they can support you and the children within your state. Next slide. Okay, so that's me. If you have questions or if you want further information about anything that I discussed today, please reach out. That's my email. And I'll hand it off to, I'm not sure who's next, but I'll hand it off to my maternal mental health colleagues from Vermont.
Thanks, Sarah. Hi, everyone. Good afternoon. My name is Catherine Wolf. Thanks for having me today. I work for the Vermont Department of Mental Health as the program administrator for STAMP, which stands for Screening, Treatment, and Access for Mothers and Perinatal Partners. And we all know that perinatal mood and anxiety disorders can have a significant influence on parental health and well-being, as well as long-lasting impacts on children's cognitive, behavioral, and academic development. Vermont is a HRSA MDR-BD awardee, and the STAMP program has been working to expand and knit together a system of care that helps to support the mental health of perinatal families. And I would like to highlight a few of these efforts today. Next slide, please. I just wanted to first acknowledge that Vermont is a HRSA Pediatric Mental Health Care Access Program awardee as well, and is actively engaged in efforts to support integrated care for pediatrics. That project is just really getting its start, so Vermont thought it would be important to share our progress on the perinatal programmatic work up to this point with STAMP. But I did just want to at least share an overview of the intentions of the PMHCA program. Given the many parallels in our goals and objectives, there are hopes for greater collaboration over time between STAMP and the Vermont PMH CAP project. Next slide, please. Just a little bird's eye view of Vermont, the STAMP program. We have made a concerted effort to assess resources, gaps, and opportunities in the existing system of care. STAMP has invested in strategies to increase capacity of providers across different settings and different regions of the state to screen, diagnose, and treat PMADs. We've had statewide trainings, including Postpartum Support International, Parents and Babies, which is the evidence-based stress management program incorporating CBT, attachment theory, and mindfulness practices. We've also had the perinatal psych consult clinicians provide training via grand rounds, and with their key support, we're currently doing a perinatal mental health Project Echo series as well. Earlier this spring, we launched a communications campaign to help elevate resources that are available to parents and families, while simultaneously educating and raising public awareness around the prevalence of PMADs. And of note, a resource and referral system situated at Help Me Grow, Vermont, has been invaluable to help streamline access once pregnant and postpartum Vermonters are identified as in need of additional support. Next slide, please. As I mentioned, in early April, we launched a new brand and communications campaign called Support Delivered. We have a website that holds general info on PMADs, as well as different resources such as Postpartum Support International, designated mental health agencies that offer PMAD support, the perinatal psych consult service that Dr. Guth will be speaking to shortly, as well as the Help Me Grow Vermont database. We're continually updating the website and hope to expand upon certain topics such as perinatal bereavement and other risk factors with time. Next slide, please. As part of this campaign, we also have high impact print materials, including posters for medical settings, brochures, one-pagers on the psych consult service, Help Me Grow postcards, what we're calling a cell sheet, or like a one-pager that's geared towards medical providers that will just kind of communicate what's available to help them treat and refer their patients for more support, I realize this image is hard to see here, but I wanted to at least give a snapshot of the feel of the campaign that was created. We're hopeful that these materials will be useful to both patients and providers, that maybe they can be sent home at hospital discharge after baby arrives, or passed off by a home visitor, or maybe posted in a pediatric office waiting room. And currently we're in the process of distributing packets of these materials to different medical and mental health settings across the state. We also have PDFs available for printing on our website. In alignment with the printed materials, we have also launched a social media and digital advertising campaign highlighting the importance of perinatal mental health and its impact on children and families. We're working on translations of these materials currently, which will also be posted to the website once ready. Next slide, please. So support delivered is essentially an umbrella of supports and services for the perinatal population. Some of the services and resources that will be highlighted include mental health clinicians with training, specialized expertise in PMADS. That includes private practice clinicians, the designated mental health agencies, and providers in other settings as well. Clinical support groups, parenting groups, other support offerings, which are both in-person and virtual. Next slide, please. Help Me Grow Vermont has been a valued partner and really a great fit as far as a centralized hub for a perinatal mental health resource and referral system, given their role in care coordination and child development resources for prenatal families through age 8. They maintain a database of providers who've received training in PMADS, and they can track, the different insurances that providers accept, the modalities they may specialize in, such as EMDR, whether they're located along the bus line, provide telehealth, and so on. And one of the many great things they're able to provide, and what sets them apart, is that they have care coordinators who can work with a parent or caregiver until they're able to make a connection. So they can serve as an ally in what can be a challenging process for an overextended parent who may not have the time to navigate finding a provider on their own, given all that's on their plate. The care coordinators can offer some names, check back in with the parent in a couple days, see how that went, and then assist from there until they can make a connection. And also, with the patient's permission, a provider can make an online referral to Help Me Grow, and the care coordinator can reach out to the parent directly to start the process. And at the end, they can close the loop with the provider. We also have a form embedded on the Support Delivered website where a caregiver can fill out the form themselves. That then prompts someone at Help Me Grow to contact them directly, just in an effort to try to minimize any burden or pressure on parents. So with Help Me Grow, you can call, text, email, or complete that online form to get connected. Next slide, please. Among the many resources on the Help Me Grow database includes our designated mental health agencies across Vermont that I would also like to draw attention to. We have 10 DAs in Vermont, excuse me, and at this stage in the life of STAMP, 7 have engaged in pilot projects in their regions, unique to the needs of their community. So we started with 4 DAs in years 1 through 3, expanded to 7 this past October. We have hopes of rolling out statewide by the end of the cooperative agreement. And these innovative projects have been so significant for Vermonters at an unprecedented time with COVID. The DAs were able to pivot services to telehealth practically overnight and meet parents and families where they're at in a vulnerable and isolating time. So it's been great. Next slide, please. And I just wanted to share a sample of the incredible work that our designated agencies are doing in different Vermont regions up to this point. Every region has invested in PMADS training for their clinicians and community partners to be more informed about perinatal mental health, how to screen, diagnose, and treat. And several of the groups have of the DAs have implemented support groups for expecting and new parents, and they've sustained strong membership despite the pandemic by providing these offerings virtually. In some regions, the DA perinatal support services are consulting with and fielding referrals directly from crisis screeners, intake coordinators, other service providers, which has just really streamlined access to services. I have to say also, we have remarkable collaboration in our state. It's a small state, and many regions have convened these coalitions in their communities with partners to help bridge gaps and foster connections that are supporting current needs of families and parents. Next slide, please. And I just wanted to take a deeper dive into a couple of our pilots. One program, Test Spotlight, is the HEART program, located at Northwest Counseling and Support Services Parent-Child Center in Franklin and Grand Isle counties. This is a rural region in the Lake Champlain Islands of Vermont. And the HEART program has been providing universal home visits up to 1 year postpartum to anyone who has given birth, experienced perinatal loss or custody loss, or supporting a newborn in any capacity. HEART was established prior to STAMP, but by engaging with STAMP, they've been able to really grow the program in terms of knowledge and professional development and concrete supports for families. And the HEART home visitors can offer an array of services now and referrals to additional programming. And for those families that are in need of a higher level of support, home-based perinatal mental health counselors can be provided anytime during pregnancy up to 18 months postpartum. So NCSS is also currently working to adapt the Parents and Babies curriculum for the Abenaki Indigenous community of Vermont that has a presence in this region, in hopes of better supporting this community with an increased risk for PMADs. So the HEART program has been a central resource in this area for families during the perinatal period, and really helps to break down barriers, such as challenges with transportation and childcare in a rural area. Another program I'd like to spotlight is the Doula Project out of Central Vermont, which is located at Washington County Mental Health Services. So this is our state capital region, where Montpelier is and beyond. And the Doula Project has been providing prenatal, labor, and postpartum support to birthing people for 8 years now. And what makes this doula program unique from others is that it is embedded in a designated mental health agency. It was designed to provide early intervention and preventative care to at-risk and marginalized families who receive Medicaid assistance and qualify for community mental health services. The doulas can provide case management support, community support, childbirth education, birth and postpartum doula supports for up to 1 year postpartum. And the Doula Project gives easy access to other services at the DA system, like various therapies, therapeutic childcare, med management, among other resources. And with STAMP support, Washington County Mental Health has now developed a STAMP doula pilot, which expands those doula services to the entire community. So there are no income requirements, no need to qualify. They have a number of doulas who, once enrolled, they're offered training, doula mentorship, case consult, a team-based approach to really support professional growth and sustainability in this field that benefits the emotional and physical health of birthing people. So after a brief phone call, families are given a list of participating doulas, and they can then hire based on that list. Families can expect 2 to 3 prenatal visits, birth support, and 3 postpartum visits. Some of the benefits of this program include decreasing maternal and infant health disparities, positive attachment and attunement, and just building up those natural and community supports. A positive collaboration with the community of hospital in this region has been a key component of this pilot. So that's just a snapshot of 2 of the DA pilot projects that are making ripples in the Vermont perinatal mental health system of care. Strong foundations have been laid to support work to address PMADs, and the response from the community has been incredibly positive to date. as Vermont gains momentum around addressing PMAD systemically. I hope this overview has given a sense of the programmatic inner workings and behind the scenes efforts to help support mental health of parents and families in our state. Next slide, please. And there's just my info if anybody has any follow-up questions or wants to take a look at our website. Thank you so much for your time. With that, I would like to turn it over to Dr. Sarah Guth, who will tell us a bit more about the Vermont Perinatal Psychiatric Consult Service.
Hi, thanks, Catherine. It's always exciting to hear about all the things that are going on in Vermont. I'm going to focus in on a couple of the initiatives that we're doing and that I'm involved in. First, the perinatal consultation service, and then we'll talk a little more briefly on our prenatal screening project. I'm going to talk about the development of these things, the successes and challenges to date. So I am a child and adolescent psychiatrist by training, but over the years of practicing child psychiatry and coming to appreciate the many determinants of pediatric mental health, very specifically parental mental health, I veered into taking care of perinatal patients because this is a time where mental health can be addressed early when people are often at their most vulnerable. So I am a part of the perinatal consultation service. Slide. And I'm going to talk a little bit about the timeline of the consultation service. It's kind of exciting to highlight in our small state how progressive it has been and how even in 2013, with our eye toward population-based health, there was a visiting nurses survey that was done to identify 50% of Vermont's mothers were found to be at risk for PMADs. So we, by 2015, my colleague, who is the other person, there are two people who do the consultation service in Vermont. My colleague is Sandy Wood, and she's a certified nurse midwife as well as a psych nurse practitioner, so very, very well trained for this position. She started a little primitive version of our consultation service, focusing on educational opportunities. She started giving talks around the state, giving grand rounds with whoever would allow her to, and taking referrals to people who, our state is pretty small, so people who could come up and be seen by her in Burlington or doing curbside consults. And the curbside consults is sort of the seed of what was to come. And in 2018, Vermont was lucky enough to be one of the states that received funding from HRSA for the maternal depression and related behavioral disorders. So that's when we sort of formalized this consult service and based it on Massachusetts, I don't know how to pluralize you, but Massachusetts Child Psychiatry Access Program. Most people are familiar with MCPAP for moms. MCPAP and then MCPAP for moms is the access program for the perinatal population. And we started doing formal consults for unidentified clients. I'm going to talk more about like the differences and similarities to MCPAP for moms in a moment. And then in 2020, we were able to start our screening program where we started screening patients for perinatal mood and anxiety disorders in pregnancy rather than just postpartum. That started at the University of Vermont Medical Center. That's the academic medical center that I work at, as well as several practices around the state. So next slide. So like I said, our service began informally, but in 2018, we created the flyer and a consult line, a telephone consult line in the spirit of MCPAP for moms. And our service embodies two of the three goals. This is sort of a tale of how we do things in a smaller state. We do the training portion. So I've highlighted these are the three pillars of the MCPAP for Moms program, and I've highlighted the first two. We do training toolkits for providers and staff on depression screening, assessment, and treatment, depression and anxiety, I would say. And we have the telephonic access to real-time perinatal psychiatric consultation, which that's part of what I do. But we don't do the care coordination, and that Catherine was talking about Help Me Grow Vermont. So that is sort of housed separately. That's sort of accomplished through the Help Me Grow Vermont referral line. Next slide. So other sort of distinctions in Vermont, in addition to the separately housed care coordination, our line is staffed by Sandy Wood and myself, so 2 psychiatric providers rather than a behavioral care coordinator. So we take the consults directly, and that works out really well. That hasn't been onerous. Another distinction is just based on the state, we are the main perinatal psychiatry providers in the state. So we are also the only 2 experts seeing patients face-to-face that also run the consult line. And this will become sort of relevant as I talk about sort of successes and challenges. And then finally, practices don't have to formally enroll to access our services. That is something the framework set out by MCPAP for Moms, and something we originally tried to instate as well. But with small, busy practices, it was hard to organize them around the trainings that we wanted to do. And we really didn't want there to be any barriers contacting us. We wanted to be available to all providers in this state. So fortunately, I can say that I think a lot of the education and training happens on the go with the consultation. So I think a lot of providers that do participate in this line are getting a lot of the training anyway. And just before we switch sides, this is our flyer on the left. It's hard to see, but I, like Catherine, I just wanted you to see what we have for publicizing this consult line. Next slide. So here's a little bit of the trajectory over the years of how things have gone, how many consults we've had each year. It's almost steady growth, with one particular aberration there from 20 to 21, which I'm going to talk a little bit about. But we really had a great peak in 2020. Next slide. So the successes, one of them I'll say is in 2021, when I was looking over how many practices we received consultations from, we had 18 practices, and that's exciting. Some of them are quite big practices too, with multiple providers, so like regional hospital outpatient programs and things. And then in 2020, our peak year, we had 52 separate consults. Also, that was very exciting. But as for a challenge is kind of trying to figure out what happened between 2020 and 2021. And as I said, I thought I had some ideas about that. And one of them is the fact that telemedicine came around. So even though Vermont's a small state, it still would have once been 3 hours for a patient to come and see Sandy Wood or myself, the consultants, the providers, same people. And I think with the advent of telehealth, well, not the advent, but the popularity of telehealth and accessibility of telehealth, we are now getting more we're now getting more referrals straight to us. And we don't always look at our referrals, we just see who comes our way. So you can see here, I said we had 291 new patients in perinatal psychiatry in 2021. That's compared with 120 in 2019. And we were offering the same availability. I didn't put 2020 in there because that was such a hodgepodge of a year, part pandemic, part not. But so what I suspect is now, rather than doing the consultation, we're seeing a lot of people directly on Zoom, which I will address in the next slide in terms of what we're doing to address that. But I also wanted to say, in terms of explaining the bump in 2020 and the decrease in 2021, I also think that we're doing a lot of training on the go. And anecdotally, at least, some of the providers that have called us a lot of times will say, I don't call you for everything anymore. I know what Sarah and Sandy are going to say. I know if a patient has become stable on then their SSRI, we're not going to stop it in the middle of pregnancy, but here we know how to talk about the risks and benefits and help educate the patient to make their own decision around it. So I think it's been a really nice, sort of learning on the go. And that might explain why we're getting some fewer calls in 2021. Next slide. So future directions, I mentioned one way to address the consult versus referral issue is we're going to be hiring a behavioral care manager who will be overseeing our referrals and hopefully optimizing what can be consults, because it really is a great program to have us providing the backup support for the provider to take care of their patients in the office that the patient is used to, with the relationships that they already have. And again, it provides more education as we do it. So hopefully someday we won't even be necessary. Another direction that we've taken, as Kathy talked about, we're increasing outreach and publicity, and we're increasing prenatal screening, which I'm going to talk briefly about, but I think that's going to create a bump in consultations, because we're going to have more screening and pick up more people who are suffering early in their pregnancy. Next slide. So just an important fact to point out is that over 50% of women with postpartum depression actually either enter pregnancy depressed or have an onset during pregnancy. So it's almost a little bit of a misnomer. I think there's a lot of speculation that the high rates of postpartum depression are just related to the fact that we're screening for depression in a systematic way in this group. So a lot of that depression, yes, reflects vulnerability, but also symptoms that may have started earlier. So based on that, we in 2020, we used the Edinburgh Postnatal Depression Survey, which is also validated for pregnancy, even though it's called postnatal. Fun fact, it's also validated for birth partners. It's very multi-use, and it captures anxiety as well as self-harm. It's a really great instrument to use, and it's only 10 questions. So our goal is to screen at 12 weeks and 28 weeks. We've really been focusing on 12 weeks at this point. Next slide. So early successes and challenges in this initiative. I'm excited to say that looking at the last quarter's data, we did 292 screenings. And in that quarter, there were about 321 newly pregnant patients that came to our practice. I think that this looks a little bit more successful than it is, because that encompasses both the 12-week and the 28-week screenings, but mostly 12-week screenings. So we're really getting most of the people who are coming through. And another success is three other Vermont practices are piloting screening programs. Ongoing challenges include busy workflow. 2020, a very challenging year to start anything. I mean, some of our patients were having telehealth appointments for their prenatal visits, and some of them were coming in, and it was kind of a mix, and it still is a bit of a mix. So there are a lot of questions around who does the screening, how does it get documented, and streamlining responses. But we're ironing all those things out, and I'm really excited to talk about it all in another year, to be able to share kind of how we've figured that out and created an algorithm for it. So that's it from me. I don't have a contact, which everybody else does, so I'm going to put it in the chat right now. This is my name, and this is my email address. I welcome questions. I'd love to work with people from other states who are doing similar things, and I'm going to turn it back over to our hosts for this.
Thanks, Sarah, and thank you, everyone. Thanks for all those great presentations. I think I'm one of 2 or 3 here to close this out. To briefly introduce myself. Oh, sorry, my computer said I was muted, but I can see that I'm not. To briefly introduce myself, Reed Plimpton, Program Manager for the Northeast Telehealth Resource Center, one of 14 TRCs across the nation funded through the HRSA's Office for Advancement of Telehealth. If you're not familiar with either NETRC or your regional TRC, I'd encourage you to be. Long and short of it is that we are here to help. Right, like most HRSA projects, increasing access to care and increasing the quality of care, especially for the rural and underserved, and the sort of added auspices of increasing the utilization and the understanding of telehealth. So if you have a question, we are here for it. We do quite a lot of different things, and I've kind of linked through some of those throughout the slides, and I will kind of answer a question I've seen a few times in the chat. You'll get all of these slides post session along with the recording. I did want to call out that NETRC, like a lot of the regional TRCs, is planning our annual conference, and hopefully our three colleagues that just presented, along with many of you along the call, would think about submitting a call for abstract for a chance to present in Massachusetts this fall, or we'd just love to see you there as a registered attendee. So those links will bring you there. And then really the last thing I wanted to do is kind of to continue the theme of, providing resources and learning. These last three slides are just quite a few different resources from various federal agencies on the topic of pediatric telehealth care and pediatric mental health with telehealth modalities. And so same thing here, just quite a few different links. I will point out that this slide's more, oriented towards the patients and the consumers, and things sort of underneath the devices. The connectivity bullet there is things that can help increase their ability to access telehealth services, whether it's through, stipends for broadband support or stipends for devices or digital equity, so on and so forth. And then just a couple other telehealth resource center libraries. One of the things NETRC's really kind of proud of is our resource library, where we're publishing where we kind of store all publicly available published journal articles and other reports on telehealth. There's over 6,000 on there right now that can be checked out. The 14 TRCs do work collaboratively together under the National Consortium of Telehealth Resource Centers. So that's the link to that website there. And you can also find our webinar series that we host as a consortium, which is on the third Thursday of every month. And then here's some contact information for the NETRC team. And I think I'm handing it over to Hadvi and our colleagues at the Maternal and Child Health Bureau Workforce for a couple of comments before we close things out.
Yeah, thank you so much, Reed, and thank you to our presenters today, Dr. Hagan, Ms. Wolf, and Dr. Goose for their fabulous presentations related to PMHCA and MDRBD. Just wanted to share a few closing remarks from the Maternal and Child Health Bureau. It's really a pleasure for me to talk about recent calls to action from Secretary Becerra and HHS agencies related to pediatric behavioral health. So just want to share, as everyone is probably aware, data from the National Survey of Children's Health highlights that the number of children ages 3 to 17 years old diagnosed with anxiety grew by 29%, and those with depression grew by 27% between 2016 and 2020. And if we look at between 2019 and 2020, there was a 21% increase in children diagnosed with behavioral or conduct problems. This data is, hasn't taken into account data collected during the pandemic. So it will be interesting to see if there will be increases in these percentages in the next iteration of the survey. I just wanted to, mention, of course, in addition to the recent joint announcement from HHS agencies and Secretary Becerra that was issued during Children's Mental Health Acceptance and Awareness Month in May. There have also been calls to action from President Biden, the Senate Finance Committee, and the Surgeon General, and of course a joint letter from the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association. So I think all of these, calls to action have really coordinated in encouraging HHS recipients across all programs to think about how you can coordinate using funds to create meaningful and equitable approaches to addressing children's behavioral health needs and expand access to high quality pediatric behavioral health care. I just wanted to touch on a couple of other things. I know that we're running short on time, but if we think about behavioral health challenges, they are a leading factor in disability and poor health outcomes for children and adolescents. we know that there's a growing crisis in pediatric behavioral health. And, we also are very fortunate to partner with the Screening and Treatment for Maternal Depression and Related Behavioral Disorders program because, untreated maternal behavioral health conditions, either postpartum or during the early childhood period can have significant impacts on the emotional and behavioral health of a child. So, we're also interested in learning more there. I think that in terms of the way that HHS agencies and programs can work together, we're really interested in how, the delivery of Medicaid early and periodic screening, diagnostic and treatment eligible behavioral health screenings may be able to be increased, through the Title V block grant program, trying to leverage those services, in terms of increasing behavioral health screenings through Medicaid. And also, what are our programs doing in terms of increasing statewide training and technical assistance for pediatric and family medicine providers to integrate behavioral health into their practices and be able to, increase the behavioral health services that they provide. That's, pretty much a primary goal of PMHCA. I think, so we're, interested in seeing how the data bears that out if we're moving the needle there. I think also in the future, we're just very interested in, of course, trying to, see how these programs can support the, limited workforce capacity for behavioral health, for pediatric behavioral health. There's still, a vast shortage of child and adolescent psychiatrists, and that shortage, doesn't look likely to be resolved anytime soon. So these programs really, are able to support clinical and community workforce capacity. And I think that, we're also interested in just how we can better partner with emergency departments, federally qualified health centers and schools and school-based health centers to bring behavioral health into EDs, into FQHCs, and into school-based health centers and schools to try to see if we can help providers in those settings address pediatric behavioral health in a more comprehensive and coordinated way. So I just wanted to end there, and I'll turn it back over to, the Region 1 staff. Thank you.
Thank you, Madhavi. Just wanted to ask you, first of all, I want to give many thanks to all of our presenters for their time, the valuable information provided, and and sharing so many resources with the potential to be replicated in other communities. We hope you can join us again for the next part of our webinar series at a future date. We will keep you all informed. And I will ask you to please complete the evaluation questions that will appear before you disconnect from the session. Once again, just want to thank everyone for attending, and yes, have a great afternoon.